And so on behalf of the organizers, we'd like to welcome and thank you for joining what we hope will be a practical and forward-looking discussion. For those online, I have to say we definitely lucked out. We have a beautiful room here. I can actually see palm trees to my right, which coming from Washington, D.C., where we are currently encased in ice. It is actually very nice here in Guangzhou. This is actually the fourth day of health working group related events. We've had a number of different discussions on healthy aging. Just this morning, I was able to participate in a workshop on respiratory disease and respiratory infections. And today we're actually combining those two issues in terms of healthy aging and respiratory disease. And for those who may not be familiar with some of the previous work on this topic, this dialogue builds on the momentum from the Apec SOM3 2025 policy dialogue that was held in Korea, where economies came together to examine the growing impact of influenza on older adults and the importance of prevention in aging societies. That discussion underscored both the scale and the challenge and the need for stronger, more coordinated policy responses. And since that discussion, we have circulated to the APEC Health Working Group a summary paper highlighting 6 practical recommendations that provide a roadmap to strengthen resilience, protect older populations, deliver health and economic returns. And just to show how intensely APEC economies view these documents, it is still being actively circulated, and we are waiting endorsement from the Health Working Group any moment. And so today moves that conversation forward, and rather than focusing on only the problem, we will also concentrate on economy level progress since SOM3, how evidence is being translated into policy, and how surveillance and data systems are evolving, and how those economies are considering improved tools, including enhanced influenza vaccines to better protect older adults. And anyone sitting in the back, you are welcome to join us here at the table. There's plenty of room there. So across the Asia-Pacific region, populations are rapidly aging. We've heard a number of different discussions on how fast the Asia-Pacific region is aging, so that will come as no surprise to anyone here. But we will look at, in terms of with that longer life expectancy comes a growing responsibility to ensure that the added years are lived in good health with independence and quality of life. Influenza may be seen as seasonal, but for older adults, it can be life-changing and life-threatening. It is a major driver of hospitalizations, functional decline, and worsening of chronic conditions such as heart and lung disease and premature mortality. But the good news, not to be a total bummer here, but there is actually good news, is that influenza is preventable. And what is really exciting is we actually now have effective tools, especially vaccination, to reduce severe illness and complications. And strengthening influenza prevention is therefore not just about infectious disease control. It is a core component of healthy aging policy, helping older adults remain active, independent, and engaged in their communities, while also reducing the strain on health systems. So today's dialogue will bring together policy leaders, researchers, and public health experts to explore how we can better use these tools, grounded in evidence and informed by economy experience, and then adapted to the diverse health system context across APEC. So if I could have the next slide. So before we begin, just a quick housekeeping note. Today's session will be recorded, and we do plan to make the recording available online so that others may benefit from today's presentation and discussions. So just want to take a brief moment to see if there are any objections. Thank you for that. And then if we have the next slide. So just in terms of interpretation, and we do apologize, we are having some technical difficulty with the Vietnamese interpretation, but we will try to work that out. But we have planned to offer live interpretation in Mandarin, Vietnamese, and Korean. For those joining in person, you can scan the QR code that you see right there and follow the instructions to connect to the interpretation on your phone. You will need to use your own headphones. Once logged into Zoom, you'll be able to select the channel for your language of preference. And then a kind reminder to everyone in the room, just please always use a microphone when speaking so that our interpreters and our virtual participants, which I know we have quite a few participating online, can hear you clearly. And For our colleagues that are joining virtually on Zoom, welcome. We're glad that you're a part of this discussion, and you may please submit your questions at any time using the chat function. We will monitor this chat and bring your questions to the Q&A segment later in the program. And you can see there, for those participating online, how you can choose your language of preference. Have the next slide. Okay, so I just want to briefly walk through the agenda for today's meeting. We will start off with some opening and scene setting remarks to frame the influenza burden in older adults and the broader policy context. We will then move into real-world evidence from Korea on vaccine effectiveness in aging populations. And then next we will hear several Apec leadership case studies, including from Chinese Taipei and Japan, highlighting how economies are translating evidence into policy, including pathways towards enhanced influenza vaccines for older adults. We will then broaden our lens to a regional level, examining system gaps, surveillance challenges, and under-recognized burden of influenza across the Asia Pacific. And then we will also hear about the Fluidity study, Fluidity HD study, which provides important new evidence on the effectiveness of enhanced influenza vaccines in preventing severe outcomes. We will then conclude with an interactive Q&A discussion. Those who ask questions, if you please have those questions ready to go. And so with that, we go to the next slide. So with that, to begin our program and help frame today's discussion, it is my pleasure to introduce our first speaker, Professor Ruben Ng. Professor Ruben Ng is an assistant professor at the Lee Kuan Yew School of Public Policy at National University of Singapore. He's a behavioral and data scientist whose work focuses on how public discourse, social perceptions, and policy environments influence health behaviors and population outcomes, particularly in the context of aging and public health. And today, Professor Ng will help set the stage by exploring how influenza and vaccination are discussed and perceived, and why these narratives matter for policy and uptake. So, Professor Ng, thank you for being with us, and the floor is yours.
Thank you so much, Ryan, for that generous introduction. So good afternoon to all of you. Thank you, and hope you enjoy your lunch. So my name is Ruben Ng, as you can see on the slide there. NG has no vowels, so it's always difficult to pronounce. So when I spend some time overseas, people always think NG is an abbreviation for no good. But I told them, no, it's not no good. It's a nice guy. I'm from Singapore, so maybe just a quick introduction. Singapore is 4 seasons: early summer, midsummer, late summer, and summer. So every day is really hot and sweltering, so it's nice to be in beautiful and cool Guangzhou. But I think Singapore has 2 seasons, indoor and outdoor. If you've been to Singapore before, indoor is always freezing cold with the air condition. The AC outdoor is just sweltering hot. So there's no good time to visit Singapore, but there's also no better time. So welcome you to come anytime. Okay. It doesn't look like this is my first slide. Is there a... Okay. Okay, so maybe just before talking about, I think the slides got switched around, but the idea here is that, you know, influenza mortality rates are a lot higher for 65 years and above compared to other groups. Now, this is an important, can I just see the next slide? Okay. Okay, so before maybe moving to this slide, I just wanted to give some background about the aging populations in the world. So everyone is talking about the aging population because the numbers are quite stark. There are some United Nations projections that by 2050, there'll be 2.1 billion older adults, 60 years and above. So what 2.1 billion means is the entire population of US and China combined and more, right? So which means that aging is going to be sort of an important key demographic driver. But the other important thing also is that, you know, I've done a lot of stereotype research, and we found that most of the time when we talk about older adults, 3 in 4 would talk about older adults to be in a very negative sort of fashion. In fact, on media, for every positive descriptor of older adults, we have 6 negative ones. So it's quite a serious issue. It's serious because there are 2 implications for this. First of all, there are a lot of studies showing that older people who think negatively about aging lived 8 years shorter than those who think positively. Okay, those who think negatively about aging also have earlier onset of hearing losses and a higher risk of recurrent cardiovascular disease. Okay, so it's not just to individual health, but also to population health. There have been a lot of studies in the US, in Europe and the UK, showing that the cost of negative healthcare stereotypes for aging actually cost the US healthcare system in excess of $63 billion. Okay, so because of that, there's an urgent need to reframe aging from one of a burden to one of a blessing, right? And one of the key ways to then reframe aging, have a more positive conversations around aging, one of the key things is preventive health. And one of the key planks is vaccination, enhanced flu vaccinations, right? So I think we want to reframe aging because the world is aging. And one of these key strategies is really vaccination. So I just wanted to set the stage, okay? This particular slide is something I'm very excited about. So I'm a behavioral and data scientist. We put together different kinds of data sets to understand narratives, because without understanding narratives, there's no way we can change behavior, right? So what we did was everything that's been published across these 20 countries, we collated online media from 2010 all the way to pretty much last week. So we could look at then the narratives of different conditions. We can look at flu. We can look at whatever kinds of conditions. So this really gives us the pulse of society, what people are talking about, what are some of these narratives, are there misinformation, disinformation, and so on. So we use this particular platform, for example, to understand policy communications. Prior to the university, I was working in the government, and sometimes from a perspective of a policymaker, what we intend to communicate is often not how it's perceived. So we try to do a dynamic understanding of how policy communications are done, how it's interpreted. If there's some misinterpretation, then we can correct it in the next news cycle. So this is the kind of platform that we use. Next slide. Okay, so what we found was quite interesting. We wanted to look at the sentiments around flu vaccinations in the news media. So the gray band is neutral. The blue band on top is positive. The red band is in the negative zone. So it's interesting that in news media, the narratives of flu vaccines are quite neutral, from neutral to positive. Now, I want you to take a look at the next slide, and that's social media. Social media, as you can see, is trending negative. Okay, so next slide compares both news media narratives about flu vaccines and social media. We can see a disillusionment gap between narratives of flu vaccines in the news media and social media. Okay, so I think it goes to show that sometimes we may have some narratives that companies and organizations put out on news media, but it's important to understand the content of negative narratives on social media as a way to counteract it. Because at the end of the day, how do we get some of these vaccines to be subsidized in national immunization programs? Or in Singapore, we have this program called Age Well SG, where Singapore is fast. We have a demographic milestone this year where we'll become super aged. Super aged means that 1 in 5 will be 65 years and above, right? So the idea here is not just what are some of the policy narratives that we can put in place, but question is there some narratives we can create from a groundswell perspective? Right. So I think from a groundswell perspective, if we can create and seed some of these narratives, then older adults, their family members, and their caregivers would be asking for these things. And that's a good way to get some of these policy changes and shifts. We can accelerate some of these things. So we kind of need to do a not just a top-down, but also a bottom-up perspective to achieve some of these policy objectives. Okay, let's see what we have as the next slide. Okay, so my session is really to set the stage for some of the distinguished speakers that will be coming, countries' case studies, and looking at some of the evidence. Now, the objective of this particular dialogue really is to look at real-world evidence on influenza burden and vaccine effectiveness among older adults. And I should mention also that sometimes when we look at older adults, we just lump them under 65 years and above. In gerontology or the aging world, we realize that sometimes we need finer age bands, because somebody who is 68 is very different, has different set of needs from somebody who is 88. So the 3 age bands beyond 65, young old, which is 65 to 74, mid old, 75 to 84, and 85 and above will be oldest old. Okay, and it's really important to think about how some of this real world evidence, not just to 65 years and above, but really for those different categories of old age, because as we know, the risk increases as somebody ages. The second point is really to discuss and to talk about policy pathways towards enhanced influenza vaccines in aging societies. For example, some of those pathways might not just be policy related, it could be groundswell related, getting people excited, getting people to request for some of these things. I think if we can do some of these things in tandem, we'll see policy changes accelerated. Number 3 is to identify system gaps in surveillance, data, and implementation. And I would say when it comes to the system gaps, we also need to look at narratives because narratives drive behavior. 4th is to support cross-economy knowledge sharing to sustain policy momentum beyond the meetings that we have here. Because I think together, everyone sort of achieves more, and to see whether we can create not just a groundswell within a particular country, but across APEC as well. Okay. With that, thank you very much.
Excellent. Thank you very much, Ruben. That was fascinating in terms of looking at how psychology, narratives, and behavior actually drive real-world outcomes. I know after hearing that, I'm definitely going to try my best to put positive vibes out there about healthy aging and vaccines going forward. Okay, so in terms of our next speaker, I'm very pleased to introduce Dr. L.J. Tan. Dr. Tan is the Chief Policy and Partnerships Officer at Immunize.org and co-chair of the Global Influenza Initiative. He has held numerous leadership roles in immunization policy, including service on U.S. national advisory bodies and longstanding work to strengthen adult and influenza vaccine programs globally. His work focuses on vaccine policy, access, and delivery systems, particularly for adult and high-risk populations. And today, he's going to help us frame the broader policy landscape for influenza prevention among older adults. And so, Dr. Tan, the floor is yours.
Thank you very much, Brian. Really appreciate being here. Thank you, Ruben, for that setup. I think a lot of what I'm going to talk about is going to follow very naturally on what Ruben has talked about. I happen to be getting towards that younger old population. And so I think I have a very strong personal interest in the fact that I want to be protected against influenza as I hit that young old population range, right? So my job for the next 10 minutes is to kind of just build on what what Ruben has kind of, Dr. Ng has kind of said. See, I'm originally from Singapore, so it's kind of, you got two Singaporeans up here kind of doing this, but I've been living in the United States for over 35 years now, maybe 40 years. But that being said, I'm delighted to kind of follow up on some of the objectives that was mentioned by Dr. Ng and kind of bring it off, kind of show you what that was like as a result of the SOM 3 meeting that was held in Incheon in August. So if I could have the next slide. This is to just basically kind of set the scene and remind everybody, and this has been already very nicely covered. So what I'm going to focus on here is basically the first box, which reminds everybody that I'm going to actually kind of summarize a recommendation paper that, as Ryan has pointed out, is still very effective, still being used. Obviously, it should be because it's very, very relevant. And that paper around everybody is titled Preventing Influenza-Related Immunizations and Deaths Among the Elderly to Promote Healthy Aging in the APEC Economy. So something to keep in mind, that paper is available. The burden of influenza is in the green box. I'm not going to spend a lot of time on that today. Ruben has already mentioned a little bit of that, and I will actually spend a little bit more time on the burden of influenza in my final presentation, which will follow John here from Apache. So my job for the next 8 minutes or so is to basically talk about the 6 priority recommendations that came and to remind everybody that they tie into what Dr. Ng has talked about. So if I can have the next slide. If you think about recommendation, I want to point out that as a result of that paper, and we will hear from these economies soon, I want to point out that there have been movement forward. And so since we're hearing from these economies, I'm not going to go ahead and spend a lot of time talking about their success and what they've been doing with regards with enhanced influenza vaccines, but move on to the next slide and focus specifically on the 6 recommendations. So the first recommendations, and remember, these 6 recommendations are all addressed to kind of move us towards understanding the best way to improve access to enhanced or better influenza vaccines as a result of data, right? So again, we need to make sure that we're putting it all together, okay? So the first recommendation is obviously very clear, right? If you have a better vaccine, you need to follow the science and you need to develop policies that enable the use of those better vaccines. So if we talk about following the science, we talk about evidence base. If the evidence base shows you have a better vaccine, you should be following that evidence. Okay, so that's something that's really important to keep in mind. And what does that mean by following that evidence? It means you got to create policies that remove barriers to access. So if your patients, if your public over 65, over 75, over 85 cannot get to what is data showing as a better vaccine, you need to think about changing that policy. So this is the first step of access. You'll hear me talk a little bit more about access in another recommendation further down the line. And so what do we need to do? We need to make sure that a lot of these barriers in policy are removed. And that means sustainable funding, that means multiple channels, and we can talk a lot about that. The paper really goes into a lot of that. And one of the things I would like to point in mind, something that we have used in the United States, although currently we're taking that off the table a little bit for reasons I think many of you might know. We used to use incentives to drive provider performance. So basically, if a provider or a physician or a clinician performs to a certain level, I get 90% of my patients vaccinated, there would be an incentive. Right? So those are things to consider in terms of enhancing your policies to improve access to vaccines. The second slide is recommendation 2. And this is about improving vaccine uptake through outreach and public awareness. So if we can have the second slide, please. Thank you. So if you are now improving access through your policies and you're pulling your providers along, the next thing you got to figure out, and Dr. Ng mentioned this, right, with that gap, is you got to bring the patients along too, right? And that means you're going to have to go ahead and reach out to these patients. You're going to have to make sure that they know the benefits of flu vaccination. And then you need to make sure that your communications are targeted at the right audience, which is these older populations that Ruben has talked to us about, to their caregivers, the people who are taking care of these folks as well. Because remember, all it takes is for a caregiver to say, huh, flu vaccine? And all of a sudden, you've lost the patient. So you got to make sure you have targeted communications and talk about the benefits of these vaccines. And there is a good leverage point. If you have a quote unquote better vaccine, that means you can tell your patients and the caregivers that we're actually trying to get a right. So something to keep in mind. The other thing also you want to keep in mind is that you need to make sure that there's an access challenges are also addressed. We talked about access challenges because of policy. Think about access challenges because of barriers, right? So older folks have a harder time finding vaccines. They have to move to a place to get vaccinated. So you got to remove all of those things. So ultimately what you have to do is you have to make it convenient for your patients to get vaccination. So convenience is the access that you have to remove, whatever that means. And then when you do all this, you need to make sure you continue to measure how well you're doing, right? We need to say, hey, if you're doing these programs, if you're educating your patients, you're educating your caregivers, are we actually seeing improvement? And if not, you need to find out why. And that's that accountability at the bottom there. Next slide, please. One of the biggest things when I go talk globally about influenza and other respiratory viral diseases is about surveillance. If you don't look for something, you're not going to see it. And if you don't see it, it's really easy to say you don't have it, right? I think you need to keep that in mind. So I think we need to make sure that we improve our surveillance systems and in general, improve data, because that first point is remarkably important. If you have better data, you will have better policy, assuming, of course, you are evidence-based, right? And that's what we want to make sure we do. So better data is not just surveillance data, which I've already mentioned, it's also coverage data. How well are you doing with your vaccination coverage rates? Surveys about your patients. Ruben has showed us some, right? He does that survey. Are the patients accepting the vaccine? And if not, find out why, right? So that's data that can improve your policy as well. And then finally, the way you get that data has to be transparent. It has to be available for everyone to know what you're doing, because that will then create trust. And as Ruben has been talking about earlier, that is trust in you, but also that is trust in the vaccination process. That's incredibly important. Next slide, please. Recommendation 4. Obviously, this one is a no-brainer, I think, in many of us, is that as you do all of this, it would be foolhardy to not be able to think about, detection, surge preparedness, and treatment, because the older adult is indeed vulnerable to flu. And you need to be able to have diagnostics to detect influenza infection in those who are older. And if you are older and you have flu, you want to treat them, right? And so that means you need to have diagnostics to diagnose, then you need to have treatments, antivirals available to treat. And in the United States right now still, we recommend that you treat without confirmation. If you have an older adult or someone who's at high risk and they appear to have influenza, you treat with an antiviral even as the confirmation test is going on. In the United States right now, it's very, very kind of neat. They have now these over-the-counter tests that test for both COVID and flu. Very nice. I used one myself a couple of months ago. It turns out I had COVID, but that's okay. It wasn't flu. But then the other final thing to remind everybody also then is that as you test, as you treat, remember that when seasonal surges happen, you need to be prepared for those seasonal surges, right? So in other words, you need to have your antivirals ready to go. You need to have those diagnostics ready to go. And you also need to have personal protective equipment, et cetera, ready to go. Next slide, please. Now I'm running out of time, so I'm going to try to wrap up very quickly. This one is a no-brainer in many respects as well. The long-term care facilities are where all your vulnerable adults are sitting. These are people who will suffer, who will die if they get influenza. So we need to do better with those folks. So we need to focus into these long-term care facilities, get them protected. And then the other thing also is to remember that once you have an outbreak in there, it will go crazy. So you need to be ready to prepare against outbreaks should they happen, which means you've got to have plans ready for infection control, whether that means cohorting, whether that means visitor precautions and restrictions, et cetera, those plans need to be in place. And then finally, as I said, the vulnerable are in these facilities. So if there is an outbreak, you need to have those antivirals ready and you need to give them. Next slide, please. And finally, I think this is incredibly important in the context of what Ruben has talked about. We need to make sure that our influenza prevention strategies and controls, treatment, prevention by vaccination, et cetera, are all integrated into the holistic environment of healthy aging. So if you have someone coming in for a checkup who is older, you should be thinking, weight, blood pressure, cardiac exam, vaccination. It needs to be implemented in those routine care primary pathways so that it is a no-brainer for your clinicians, for your providers to do that. And then what I can tell you, and this is indeed true, and I'll show you a little bit of this in my next presentation at the end of this session, is that if you do this right, not only will you be saving lives and improving the quality of life for those of your population that are older, you will actually be delivering cost effectiveness and cost savings to your economies as well. Last slide, please. I'm going to stop right here. Thank you all very much for your attention, and I'm delighted to hand this back to Ryan.
Excellent. Thank you, LJ. I think that was a great presentation of the recommendations. I mean, a lot of them are kind of common sense, but I think it really helps to lay them out as you have. I mean, particularly if we have, a better vaccine, we have a better mousetrap, we should be using it. Incentives drive action. I know I have 2 young kids, and certainly they are very motivated by both money and access to video games. So I can definitely say that incentives definitely do matter. We have to make it convenient. You have to meet people where they are. And I think no data doesn't mean no problem. So we do need to collect data. And if we do have better data, we will have better policy. So thank you very much for that, LJ. So our next speaker is Dr. Won-Suk Choi. He's a professor of infectious diseases at Korea University College of Medicine. He's going to speak on some of the real-world evidence that has been generated through at Korea. He serves on multiple national advisory committees and immunization and health crisis response, and also chairs the Adult Immunization Committee of the Korean Society of Infectious Diseases. His research focuses on vaccine effectiveness, immunization policy, and infectious disease burden in aging populations. And as I said, he's going to share some recent findings on influenza vaccine effectiveness in older adults. And we're very pleased to have Dr. Choi online with us, although we're actually going to show a video just because of some of the technical challenges we're having earlier today. So we're going to show a video, but Dr. Choi is with us to participate during the Q&A session. So can we cue up that video?
Good afternoon. Thank you for this opportunity to speak today. My name is Won-Seok Choi from Korea University College of Medicine. Today, I'd like to share real-world evidence from Korea and discuss policy implications for influenza prevention in older adults. My key message is simple. In rapidly aging societies, standard dose influenza vaccination strategies are no longer sufficient, and we need to consider more effective approaches. The Asia-Pacific region is aging faster than any other region in the world. By 2050, 1 in 4 people in Apec economies will be over 60 years old. This demographic shift is already shaping our health systems. At the same time, influenza remains a major cause of hospitalization, mortality, and economic loss through healthcare costs and caregiving burden. Therefore, protecting older adults from influenza is not only a health priority, but also a key issue for economic resilience and sustainability. Influenza does not affect all age groups equally. Among older adults, 65 and older, influenza-related hospitalization and mortality increased sharply. More than 70 to 90% of seasonal influenza-related deaths occur in this age group. Older adults are 5 to 10 times more likely to be hospitalized due to influenza complications. Influenza can trigger acute cardiovascular events, such as myocardial infarction and stroke, making it a serious systemic disease in seniors. Let me see the real-world evidence from Korea. The hospital-based influenza morbidity and mortality, or HIM network, is a multi-center surveillance system covering 8 large university hospitals. It focuses on adults hospitalized with severe acute respiratory infection using a test-negative case control design. The object of this network was to evaluate real-world effectiveness of a standard dose influenza vaccine. Korea presents an important paradox. Among adults aged 65 and older, influenza vaccine coverage is close to 85%, one of the highest levels globally. So access and uptake are not the main problem in Korea. However, when we examine real-world effectiveness, the results much less reassuring. Vaccine effectiveness was only 13.5% older adults. In all others, it was 24.3%, and in younger adults, it reaches 36.2%. This shows that even with excellent coverage, protection in senior remains limited. This challenge is therefore not coverage, but insufficient immune protection in older adults. Another important issue is waning immunity. Vaccine protection declines within the same influenza season. Early in the season, effectiveness is higher, but later in the season, it drops substantially. This leaves older adults vulnerable during late season influenza surges, even though they were vaccinated. So we face 2 simultaneous problems: a weak initial immune response and faster decline of protection. Let me turn to international experience. On this slide, I show data from the United States, United Kingdom, and Australia. Well, enhanced influenza vaccines are widely used in older adults. In the United States, vaccine effectiveness against influenza-related hospitalization in adults aged 65 and older has generally been reported 30 to 40% in recent seasons. In the United Kingdom, surveillance data shows vaccine effectiveness in older adults, typically around 35% or higher. In Australia, national surveillance records indicate that vaccine effectiveness against severe influenza outcomes in seniors is commonly in the 30 to 40% range. These figures are clearly higher than the 13.5% observed in older adults in Korea. This suggests that the difference is related not only to aging, but also to the type of vaccine used. This slide provides more direct evidence. In France, a large national cohort study using insurance database shows that the high-dose influenza vaccine was 27.4% more effective than standard dose vaccine in preventing influenza-related hospitalization among adults aged 65 and older. In Spain, regional real-world data shows that high-dose vaccine provided about 34% protection against severe influenza outcomes compared to standard dose vaccines in seniors. In addition, meta-analysis combined data from multiple countries consistently confirmed that enhanced vaccines reduce hospitalization and serious complications more effectively than standard dose vaccines. Why do standard vaccines perform less well in older adults? The main reason is immunosenescence or immune aging. With aging, antibody response are lower and decline more rapidly after vaccination. Standard dose vaccines often do not provide sufficient immune stimulation to overcome this biological limitation. Highly immunogenic vaccines help address this problem. High-dose vaccines increase antigen exposure, and adjuvant vaccines enhance immune activation. In short, enhanced vaccines are designed to compensate for immune aging. Enhanced vaccines are more expensive per dose. However, policy decisions should focus on the value, not price alone. If enhanced vaccines prevent hospitalization and ICU admission, they can reduce total healthcare costs. Importantly, cost-effectiveness analysis have been conducted in Korea, and these studies show that highly immunogenic influenza vaccines can be cost-effective for older adults. So, the economic argument is not only international, but also relevant in Korean context. Based on this evidence, I propose three strategies. First, prioritize enhanced influenza vaccines, such as high-dose or adjuvant vaccines for adults aged 65 and older. Second, adopt value-based procurement using real-world evidence rather than focusing only one unit price. Third, strengthen regional collaboration within Apec to harmonize influenza surveillance and vaccine effectiveness evaluations. In conclusion, older adults remain the most important target group for influenza prevention. In Korea, vaccination coverage is very high, but real-world effectiveness in seniors is still low. This clearly tells us that we need a better prevention strategy for aging societies.
Excellent. Thank you very much, Dr. Choi. I think that was actually a beautiful representation of what LJ was saying earlier, just in terms of the importance of following the science, following the evidence. So I think presenting those studies, I think, really brought that home. And certainly what you're saying about immunosenescence certainly makes sense to me. I'll be turning 50 next year, and I certainly do not get over jet lag as easy as I used to, don't get over going to the bar as easily as I used to, and also my kids now will bring home some sniffles, and I'll be sick all winter. So it definitely makes sense to me. So now in our session, we're going to move on to the Apec leadership cases, policy pathways to enhance influenza vaccines. And our first Apec leadership case comes from Chinese Taipei. And so we are very honored to have Dr. Yi-Chun Lo, who's Director General and Specialist in Infectious Diseases. He has played a key role in outbreak response, risk communication, and vaccine policy during the COVID-19 pandemic. He served in senior leadership roles within the Central Epidemic Command Center, and today he will share how Chinese Taipei is strengthening influenza protection for older adults and translating evidence into vaccination policy. And so, Dr. Lo, we're very pleased to have you attend virtually, and the floor is yours. I don't think we could. You may be muted, Dr. Lo. We cannot hear you here.
Can you hear me now?
Yes, we can.
Thank you, Ryan. So good afternoon. It's my pleasure to share the experiences from Chinese Taipei about the pathways that we have recently gone through to officially endorse enhanced influenza vaccines as our policy. Enhanced influenza vaccines, as the professors has already described, are among many of the new vaccines that could have significant public health benefits. And a big question for our policymaker is how could a new vaccine be endorsed as a policy? That would involve governance and the financing mechanisms. In our example, we have a law that mandates a vaccine fund for vaccine purchase and program expenditures, and the fund's financial input was kind of sustainable, mainly coming from annual budget and tobacco health surcharges. The law also mandates an approval process for all new vaccine purchase be based on ACIP recommendations and prioritized by cost effectiveness studies to avoid political influence. As shown in the graph on the right, a large input from annual budget occurred during COVID for us to respond to the surging need for COVID vaccine purchase. However, the input reduced after COVID, and we were still being able to keep it higher than pre-pandemic era in order to first accommodate more demand for administration and the preparedness cost, and hopefully in the future for adopting new vaccines. However, for 2026, we literally didn't have any additional budget into the new vaccine purchase. The reason that input into the vaccine fund does not prioritize new vaccine purchase is related to our post-COVID health challenges. As many of you have mentioned, our population in the region and also in my economy is rapidly aging. We have officially become a super aging society at the end of last year. We have also been facing healthcare workforce shortage, surge of various respiratory infections, and continued vaccine hesitancy, particularly among elderly adults. Therefore, the policy decision was before adding any new vaccine to overwhelm the healthcare system, we should have additional investment going to vaccination workforce first to sustain their capacity. Starting from next month, the vaccine administration fee per dose will be increased. And also there has been additional incentives given to the workforce as a award for vaccinating priority groups such as the elderly population. We have also established more private partnerships such as industry with supermarkets and a celebrity as shown in this picture to advocate vaccine confidence, as well as efforts and quick actions and transparency to vaccine-related events or misinformation. With this work, we want to promote healthy aging through public trust and a better uptake of influenza, COVID, and pneumococcal vaccines, all offered currently free of charge to adults with eligible criteria. And for updated vaccines, for pneumococcal vaccines, all upgrade to a newer version will be ongoing this year, and that wouldn't add any significant cost to our program. However, for enhanced influenza vaccines, the price is higher, and elders in the long-term care facility has been announced to be the first group to start receiving them in October this year. That will be around 200,000 people, a relatively small additional cost incurred around $25,000 through the program, which can still be covered by the balance reserve in the vaccine fund. Before announcing the new policy, actually a cost effectiveness analysis similar to what Professor has described was already carefully conducted locally by an independent institute in 2024 for the two available enhanced vaccines, adjuvanted and high dose. The conclusion of the analysis was, compared to the standard dose vaccines, both enhanced vaccines further reduce influenza-related visits and hospitalization. And cost effectiveness can be achieved with lower than market price, which is a good news for our price negotiation. Also, the benefits are better for the more extremely aged groups above the age of 75. The results were presented in our ACIP last year and led to the decision of ACIP's recommendation of changing to enhanced vaccines for elders as a priority policy direction. And despite no additional financial input in 2026, we're going for the new vaccine purchase. Given that the fund balance reserve was still enough, we decided to start enhanced vaccines in a smaller amount, 200,000 doses, to the elders in the long-term care facility first. We'll also conduct a survey this year to evaluate elders' attitudes of change into enhanced vaccines for our better estimation of how much more enhanced vaccines we'll be able to prepare or purchase in the following years. The reason behind our decision of first introducing smaller amount and gradual way of enhanced vaccines is not just because of money, but also the vaccine hesitancy issue among elders. You can see here from the graph that the influenza vaccination rate over the past decade has been only around 50% without obvious improvement. Three major reasons for not being vaccinated during our survey are first, worry about side effects, and also second, worry about interaction with the self-health conditions, and also the false belief that vaccines can make somebody easier to be sick. And in contrast, only 8% mentioned protection as an issue. So whether a more protective, better enhanced vaccine can really drive up the uptake is still questionable. During the policy discussion, a few other questions also were raised. For example, whether we should go to the extremely elders first to be at the first vaccinated group based on the analysis conclusion. However, we were also worried that based on the COVID-19 vaccine experiences, many non-related incidental deaths after injecting the extremely elderly group after the new vaccine would be inevitably frequent. And when media over-reports these events, the negative public impression questioning the new vaccine safety will be devastating for the policy. That's why in the end, we choose to go first to elders in the long-term care facilities who have already better vaccination rate around 80% and can be better monitored and managed by their caregivers. We also decide to purchase both enhanced vaccine, adjuvanted and high doses, given that they were determined as equally effective by our ACIP and also to allow for individualized consideration. Other concerns such as implementation, misinformation, media events will also be addressed to stakeholders and our local health partners carefully before, during, and after this year's launch. Besides endorsing new vaccines, how to increase elders' vaccine uptake is still crucial and is still our priority. We have been integrating influenza and the COVID vaccines into one campaign for the second year. and uptake is much better than 2024, thanks to the following driving factors. First, there was an unusual autumn influenza surge right before the October campaign, and the extensive warnings from the news and also from the medical groups become a major driving force for vaccination. Second, an earlier media coverage earlier last year of regional superstar Bobby She's death from influenza highlights influenza as a potentially severe disease, which became very motivating for many people's vaccination behavior. Finally, the community engagement and the outreach efforts were instrumental to promote vaccination as a happy and a healthy lifestyle. This slide shows some of the community activities we conducted, including collaboration with supermarket chains to have on-site vaccination service with store-provided rewards such as bananas and bottled water when customers get the vaccines. The private sector also invited a famous 69-year-old local actress on the right-hand side, whose nickname is the most beautiful auntie, as the campaign ambassador. She danced with a family doctor to create a vibe, and the auntie's video became viral online and made the co-administration campaign fun and good to dance along. In summary, our policy pathway was in the context of addressing post-COVID challenges such as super aging, public fatigue, and reduced financial input. The lessons learned are while advocating priority and the investment in new vaccines, always put workforce first to win their support, not to overwhelm them with additional burden. And while evidence-based evaluation is crucial, be sure to address concerns carefully to gain public trust and prevent chaos. Community engagement is key to work against vaccine hesitancy. With these coordinated efforts, we will have a better edge in advocating more investment into the immunization programs. Thank you for your attention.
Excellent. Of using celebrities as spokespeople to get the message across in terms of the importance of vaccination. And then also, I think you also had a great example of how removing barriers by providing vaccines free of charge. And then also, as we discussed earlier, kind of meeting people where they're at. So actually targeting those elderly centers first. And I think it's really helpful and important to hear how different APEC economies are actually approaching this issue, including through the use of either pilot or small scale introductions first, and also just how you thought through it and what are some of the key questions that your group identified. I think that's very instructive for other APEC member economies. So next, we'll move on to our next APEC leadership case, and that is from Japan. And so I'm very pleased to introduce Dr. Sakaya Takanashi, who is the chief of the Division of Immunization Policy at the National Institute of Infectious Diseases at the Japan Institute for Health Security. Dr. Takanashi her background actually spans clinical pediatrics, academic research, and national immunization policy, and she has been closely involved in evidence reviews and policy discussions related to influenza vaccination for older adults. And today she will walk us through Japan's policy pathway towards the introduction of enhanced influenza vaccines, including the role of surveillance data, effective evidence, and cost-effectiveness analysis. So Dr. Takanashi, thank you very much for joining us, and the floor is yours.
Thank you very much for your introduction. Yes. Good afternoon. Thank you very much for the opportunity to talk today. My name is Sayaka Takanashi, presenting on behalf of the National Institute of Infectious Diseases Japan. In this presentation, I will share Japan's experience and current policy context regarding influenza prevention in older adults. Let me begin by outlining today's presentation. First, I will briefly introduce Japan's National Immunization Technical Advisory Group, or NITAG. I will then describe the influenza surveillance system in Japan, followed by recent evidence on the effectiveness and safety of high-dose influenza vaccines. Next, I will touch on ongoing cost-effectiveness analysis, and finally conclude with key messages. This slide illustrates the institutional framework of Japan's National Immunization Technical Advisory Group, or NITAG. The NITAG is positioned as an independent advisory body that provides scientific advice to the Ministry of Health, Labor, and Welfare. It reviews evidence on disease burden, vaccine effectiveness, safety, and economic evaluation, and discusses these issues through expert subcommittees. Based on these discussions, the NITAG supports transparent and evidence-based immunization policy making in Japan. As shown on this slide, the vaccine subcommittee requests the National Institute of Infectious Diseases to create fact sheets to support vaccine evaluation. These fact sheets are intended to summarize scientific evidence in a standard and accessible format to serve as a shared evidence base for discussion within the NITAG. To date, the National Institute of Infectious Diseases has developed fact sheets for 23 vaccine-preventable diseases. These fact sheets are publicly available and are regularly updated as new evidence emerges. The most recent fact sheet, issued on October 22nd, 2025, focuses on influenza vaccines for older adults, which is the main topic of today's discussion. This slide outlines the key components of the fact sheet on influenza vaccines for older adults. It begins with basic knowledge of influenza, including clinical characteristics, epidemiological features, and the history of vaccine introduction. It then reviews evidence on vaccine efficacy and safety, followed by an assessment of cost effectiveness. Together, these elements provide a comprehensive and structured basis for evaluating influenza vaccination strategies for older populations. Japan's influenza vaccination policy has evolved in a stepwise and evidence-based manner. In the 1990s, evidence was limited regarding population-level impact, which led to a cautious approach to routine immunization. As scientific evidence accumulated, particularly on preventing severe disease among older adults, Japan shifted toward protection. More recently, with the approval of high-dose vaccines and ongoing cost-effectiveness evaluations, Japan is moving toward enhanced strategies for an aging society. Japan operates a comprehensive national influenza surveillance system that integrates sentinel reporting, virological surveillance, hospital-based monitoring, and mortality data. This long-standing system allows timely tracking of seasonal trends and circulating strains. However, like many economies, linking surveillance data to hospitalization, severe outcomes, and economic burden, especially among older adults, remains a challenge. Strengthening these linkages is critical for evaluating enhanced influenza vaccines and informing future policy decisions. To overcome these limitations, nationwide health insurance claims data from Japan's national database, NDB, were analyzed. The result shows that influenza-related hospitalization, severe outcomes, and mortality are higher among adults aged 65 years and older, and increase with age. This underscores the significant influenza burden in older population. This phase 3 randomized trial conducted in Japan evaluated immunogenicity of a high-dose quadrivalent influenza vaccine compared with a standard dose formulation. Approximately 2,100 participants were enrolled across 10 clinical sites during the 2020 to 2021 season. The primary endpoint was the immune response at 28 days after vaccination, assessed by hemagglutination inhibition antibody titers and seroconversion titers. Results showed that the high-dose vaccine induced significantly higher antibody response across all 4 vaccine strains and achieved higher seroconversion rates compared with the standard dose vaccine. These findings demonstrate the superior immunogenicity of the high-dose vaccine, supporting its role in enhancing protection, especially in older populations. This slide summarizes clinical effectiveness evidence from a systematic review published in 2023. The review included 6 randomized controlled trials and 15 observational studies covering 12 influenza seasons and approximately 45 million individuals. Across seasons, the high-dose influenza vaccine consistently demonstrated superior effectiveness in preventing influenza illness and hospitalization compared with standard dose vaccines, regardless of whether circulating strains match the vaccine antigens. Importantly, age-stratified analysis shows that relative effectiveness increased with advancing age, highlighting the added benefit of high-dose vaccines in older adults. This slide summarizes safety data from a phase 3 randomized clinical trial conducted in Japan. The safety of an intramuscular high-dose quadrivalent influenza vaccine was compared with a subcutaneous standard dose vaccine in approximately 2,000 participants. Local and systemic reactions within 7 days were slightly more frequent in the high-dose group. However, severe reactions were rare and occurred at similar rates in both groups, and serious adverse events were uncommon and comparable between groups, and none were considered related to vaccinations. Overall, the high-dose influenza vaccine demonstrated an acceptable safety profile. This slide summarizes the assumption and methods of an unpublished cost-effectiveness analysis conducted by a Japanese research group. The analysis evaluated policy options introducing high-dose influenza vaccines at different age thresholds, including 65, 70, 75, and 80 years and older. The price of the high-dose vaccine was assumed to be 5,000 yen, with full selection among the vaccinated people. The analysis was conducted from the healthcare perspective and included both vaccination costs and medical costs. Epidemiological parameters and vaccine effectiveness inputs were derived from published international studies, and vaccine effectiveness was assumed to last for 1 influenza season. This slide shows the results of the scenario analysis among adults aged 65 years and older. Among the evaluated policy options, introducing the high-dose influenza vaccine for adults aged 75 years and older demonstrated the most favorable cost effectiveness. As the eligible age thresholds increased, the incremental cost effectiveness
Recording in progress.
ICER generally improved, reflecting the higher disease burden in older age groups. These findings suggest that targeted introduction of high-dose vaccines to older populations may maximize health benefits while maintaining economic efficiency. This slide summarizes Japan's evidence to recommendation assessment for high-dose influenza vaccines. Older adults experience a substantial and increasing burden of severe influenza outcomes, as demonstrated by national database analysis. Evidence shows that high-dose vaccines provide superior protection against illness and hospitalization compared with standard dose vaccines, with acceptable safety and greater relative benefit at older ages. Cost-effectiveness analysis further suggests that targeted introduction, particularly for adults aged 75 years and older, may offer the greatest value. Taken together, these findings support adding high-dose influenza vaccines as an option within the routine immunization program, while continuing policy deliberation on age eligibility and implementation to ensure sustainability and equitable access. In closing, Japan's experience suggests that targeting high-dose influenza vaccines to the oldest adults could maximize both health protection and economic value in aging societies. For Apec economies facing population aging, Japan's approach illustrates how evidence-based stepwise policy decisions can support more effective and sustainable influenza prevention strategies. That's all from my side. Thank you very much for this opportunity. Thank you.
Recording in progress.
CARS, this is Singapore. So CARS were talked about 50 times more than flu vaccination. And get this, than flu vaccinations.
Back to you.
We're back on? Okay. It's simple but urgent. To reduce the burden of influenza and other respiratory diseases across our region. We were established in 2011 as a charitable institution in Hong Kong. Our membership includes hundreds of experts in influenza and respiratory diseases. We advise public health awareness programs, support healthcare professionals, assist with country-specific recommendations, and work to improve access to vaccines and antivirals. Our role, Apache, is to act regionally and globally to connect evidence expertise. Next slide, please. As Jacqueline Katz, influenza is constantly changing. This is not a static virus or faceted pandemic risk. Being ahead of the game requires strong surveillance, rapid and effective diagnostics, and the ability to detect unusual patterns early. Yet across much of the Asia Pacific, we are still not seeing the full picture. Next slide, please. The Asia Pacific is aging faster than any other region in the world. Notice how this has been brought up in basically every single presentation today. It is a critical element. To repeat, in 2024, more than 720 million people in the Asia Pacific were over 60 years old, 15% of the population. By 2050, it'll be a quarter. For flu, age is not just a demographic statistic, it is a risk multiplier. Once you pass 65, influenza becomes an increase to be termed the old man's friend, driving hospitalization, disability, and mortality. Doesn't sound friendly, but relative considered a peaceful method. The demographic shift alone demands a rethink of how we approach influenza prevention. Next slide, please. Influenza causes between roughly 300,000 and 650,000 deaths globally each year, but we're normalized to it. We don't notice it. We consider that to be fairly standard. The highest burden for these deaths exists amongst older adults. Across Southeast Asia, influenza remains a silent epidemic. It's persistent, but it's overshadowed by other health priorities. 4 drivers help shape this burden. This demographic wave that we've been talking about all afternoon. The rapid aging increases your vulnerability. Comorbidity crisis, the incredible growth of NCDs, particularly in the older population, along with other morbidities, put you at higher risk for influenza, severe influenza. In the tropics and subtropics, you have a really complex seasonality, multiple peaks and year-round circulation. This year, that got as far as Northern Australia, where they had an outbreak in Darwin in the middle of the Australia. The systematic underdiagnosis means many cases are misclassified as pneumonia, cardiovascular disease, or chronic respiratory illness. Together, this all masks the true impact of flu. Next slide, please. To better understand these gaps, I supported underlying research and helped to draft a resultant white paper across 4 economies: Singapore, Malaysia, Thailand, and Vietnam. We asked one question: are we truly seeing the impact of influenza, especially amongst older adults? Through interviews with clinicians, public health leaders, geriatricians, and academics, we sought to uncover the real burden, practical solutions that could be implemented within existing systems. Next slide, please. Clinicians across the economies were clear. Adult influenza sources. Experts emphasize the prevalence and severity of complications in older adults, despite public perception of minimal. Found in Singapore, there are high costs for PCR testing, very little self-testing, although perhaps the double now, and older adults are underrepresented in ILI data. In Malaysia, we were told there's uneven testing, delayed reporting, and common misclassification of severe cases. leading to incomplete reporting. In Thailand, there's a reliance on low sensitivity rapid tests and these blind spots collectively obscure the true disease burden. Next slide, please. Underdiagnosis is widespread, especially amongst older adults who often present with atypical symptoms. We've heard them several times this afternoon: pneumonia, cardiac events, COPD exacerbations, diabetes destabilization are frequently coded because of this influenza hiding in plain sight within chronic disease and complex seasonality. It amplifies complexity. Next. Thank you. So what do? Vaccination remains our most effective tool, but uptake across identified the following factors contributing to suboptimal intake. In Singapore, they noted uptake remains moderate due to a low perceived risk. Malaysia lacks a universal population, is often seen as more travel-related vaccination, but has and funds vaccination for older adults, but supply constraints and a short campaign window limit the coverage. Across all remains a major barrier. Next slide, please. High coverage action. As Dr. Wonsuk Choi mentioned earlier, I presented very clearly earlier, South Korea's 2023-24 flu season demonstrated this clearly. 80% coverage amongst older adults, 13.5% for vaccines to provide stronger, longer-lasting immune responses in older adults. Differentiated vaccination strategies, incorporating enhanced vaccines, high dose, other types of enhanced vaccines are essential if we want to reduce. High-dose vaccines have already shown significant public health impact globally. Countries using high-dose vaccines have seen visits, hospitalizations, and deaths. As noted here, in the United States, high-dose prevented more than 21,000 hospitalizations annually and generated an estimated $4.6 billion in saving over 10 years. These aren't theoretical benefits, they are real, measurable, and relevant across the region. Next slide, please. Please forgive a very busy slide, but what this table means to show is that model-based analyses working that enhanced vaccines are cost-effective and in many cases cost-saving. For governments concerned about budget impact, the message is clear. Enhanced vaccines are not only clinically beneficial, they are economically sound investments. And we've heard that multiple times earlier today. To secure next slide, please. To secure political will and expanded vaccination programs for older adults, we need accurate burden data. 3 priorities to achieve this goal stand out. We need to learn from COVID. Extraordinary capability in rapid testing and digital integration during the pandemic. Don't let that die. Do not let that fade away. Put that to use. Adopt actionable data and enable evidence-based policy. Vaccine timing, identify priority groups, evaluate real-world effectiveness, and strengthen pandemic preparedness. Next slide, please. Strengthening surveillance requires coordinated action across at least these 5 areas. You need to leverage data to optimize vaccination strategies, including enhanced vaccines for needy populations. Improve laboratory capacity by expanding PCR access and rapid molecular diagnostics. Enhance data sharing between ministries, academia, private hospitals, and laboratories. Strengthen data quality with routine age disaggregated data comorbidity indicators and outcome tracking, and secure sustainable funding for sentinel sites, genomic sequencing, and communication campaigns. These steps are achievable within existing health system structures in the Asia Pacific. Next slide, please. While the situation varied in the 4 economies surveyed, experts across the Southeast Asia region were united in their message. Older adults are at risk. We need to do more to protect them. They know preventing influenza also prevents a range of serious or critical comorbidities. Governments have strong evidence-based incentives to invest in vaccines for the elderly. And we now better understand the criticality of this type of life course immunization. Their voices reinforce what the data already shows us. Action is possible, financially prudent, and to be blunt, overdue. Next slide, please. To close, the true burden of influenza in the Asia-Pacific region is still not clear, in that invisibility has consequences. Aging populations, chronic disease, seasonality demand stronger surveillance and more effective vaccination strategies. Enhanced vaccines, improved diagnostics, and better data systems offer a clear path forward. We act now, we can reduce hospitalizations, prevent deaths, and support healthy aging across the region. We can actually be ready for the demographic changes we're all going to face, and the respiratory
example of kind of better data leading to better policy, and kind of no data not. I had a younger friend actually who did not get his flu vaccine this year, and it essentially kind of ruined his Christmas vacation. So that was unfortunate. But for older populations, it really can lead to hospitalization and death. And even with as a underreported disease, you're looking at up to 650,000 people dying. That's essentially in the city of Washington, D.C., dying every year from a preventable disease. So that is very sad. So with our next presentation, we're going to reintroduce Dr. L.J. Tan, who's going to talk about the Fluidity HD study. This study provides important new evidence on the effectiveness of enhanced influenza vaccines in preventing severe outcomes among older adults. And so, Dr. Tan, the floor is yours.
I want to just, before I start, emphasize that if you look at the Apache recommendations, they align really strongly with the paper that came out of some 3 with the 6 recommendations. So I think it's important that the strategy, I think you just have to think about how to apply them to your own economies and figure out how that's going to work. And then in the United States, I think we can tell you one step further is that influenza is important, not just for all the reasons we've talked about, adult vaccines. If you can do flu vaccination, you can do all the other adult vaccines. And in the US, I think we're really looking for how we can continue to do that. So I think this is what you use, the foundation for all other adult vaccines, pneumococcal, zoster, RSV, et cetera, and COVID, obviously, I don't want to drop that one too. So just being on as an expert in the field, I do not represent a position from either my employer, which is immunis.org, it's National Adult and Influenza Immunization Summit. That's 130 organizations. I am not speaking for them. And lastly, I also chair the Global Influenza Initiative, and I am not speaking GII either. So just have to put that disclaimer out there. Next slide, please. And so I'm delighted to now talk about Fluidity. I don't have interest, except to remind everyone that this study, Fluidity HD, as well as DanFlu2, as well as GalFlu, was funded by Sanofi. While they participated in study design, collection, and or the data analysis. Next slide, please. So I'm not going to spend a lot of time on my next few slides because you've heard in the world and in your economies, but I do want to go through them quickly just to remind us as it sets me up for the next part of my conversation. Next slide. But you've seen hints about this data in many of the presentations today. And just to remind everybody that for anybody, flu is a pro-inflammatory disease, which means that it actually exacerbates or it creates inflammation within who is older and undergoing something called inflammaging, which is the systemic aging inflammation that's associated with it, that's actually doubly bad, right? So what does flu infection do? It has this cascade of events, which includes inflammation, and a lot of the inflammation is caused by something called a cytokine storm. I'm an immunologist by training, and that's a really big word. What that means is that you've got all these chemicals in your body, it floods your system, it stirs up your inflammation processes, right? So macrophages come out, dendritic cells activate, you get interferon gamma, all these chemicals come out, and you go into this active inflammation response, which is the result. You can take a look at some of the is on influenza risk in people with these complications, right? And that means if you have these diseases, this is what it can cause, right? So I'm just going to highlight, for example, the one that we've talked a lot about right now is cardiovascular disease. If you take a look at, I'm trying to find it on here. It is the second one down. Tenfold increased risk of heart attack in adults 40 years of age and older 3 days after a post-influenza infection. So that means you get flu 3 days later, substantial population, tenfold increased risk of having an acute myocardial infarction. If you look at diabetes, the data is beginning to accumulate on diabetes, and that is the bottom, second from the bottom on I think it's on your right. 70% increase in glycemic events in adults with type 2 diabetes. So all of these folks who are suffering from chronic conditions, if you get flu, you will suffer severe consequences. So that's one of the reasons. This is morbidity. This is why we want to stop flu. Next slide, please. And then if you think about its impact globally, I think I'm not going to spend a lot of time and read through this, but just to remind everybody, seasonal influenza, right? Ryan talks about it. He talked about it earlier. He's almost 50. He goes home. 1 in 5 children catch flu. So adults also catch flu. That's many of us go, oh, you know what, it's flu. But you know what the problem is that if you're in a high-risk group, and in the United States, 75% of our population, adult populations, are in some high-risk groups, right? If you have diabetes, you're obese, you have cardiovascular disease, you have chronic obstructive lung disease, 75% of our adults are in a high-risk group. In those high-risk groups, influenza is more than just a bad 3 days in bed. It also is death. It also is, and it's not on this. When I give talks to my older populations, I go to long-term care facilities in the United States, and I volunteer to talk to them about flu vaccine. They don't come up to me and say, LJ, I'm afraid of dying. In fact, many of them have actually reconciled themselves to what their life is, and that death is actually not a bad thing for them, right? Old man's disease, right? But what they talk to me about is, LJ, I love what I'm doing now. I cook in my little kitchen. I meet with my little friends. I go out takes me to local pharmacy. We go shopping. I like doing all of that, even though it's assisted. But problem is, if you flu and you're not vaccinated, all that can go away. What I like to tell people is that if you are not vaccinated and you're 65 and older and you catch influenza, you'll walk into a hospital, but 3 weeks later, you'll come out with a walker. Next slide, please. Influenza, and I think it's important to keep in mind that the cost of severe the illness is, right? So severe outcomes are rare, but they tend to be the bigger cost burden because they cost more. If someone gets hospitalized, you're looking at about $8,000 United States dollars to remedy that position. Whereas if you have $7, and while the attack rate is much, much lower, it's still much higher in those who are 65 and older. So again, focusing in on elderly population is incredibly important because the number that was given earlier, 67% mortality rate in that can get as high as 93%. our mortality in influenza in one season is in the 65 and older population, just to keep in mind, depending on the season. Next slide, please. This is actually data that is just released. This is hot off the presses. And unfortunately, the slide got cut because it's so hot off the presses, I couldn't cut and paste that table properly. That's the bottom right hand. But first, let's talk about the top left-hand side. This is an economic analysis of cost burden of the 23-24 influenza season in the United States. And this was a really, really bad season. And this paper actually looked at indirect costs as measured by productivity losses. And the total cost as a result of influenza because of healthcare direct costs, as well as productivity indirect costs, was I'm willing to pause.
I mean, I can't, what are
So thank you.
sincere.
Thanks for fixing the audio.
Yeah.
So I think this is what this is called here. You know, a better vaccine is protection beyond flu. What does that mean? It means beyond just getting flu, right? So right now, if you take a look at how flu vaccines are measured, we look at immunogenicity data. You saw a lot of that in Dr. Wan's presentation and other presentations about how the flu vaccine improves in the antibody response. Very good. Then we also look at clinical endpoints, right? We look at infection data. That's the one we're talking about. How many cases did they prevent? What we're trying to do now, and we're beginning to see it, is we also need to look at hospitalization data. And that's what else it can prevent. If you get vaccinated, you're less likely to be hospitalized, especially if you're 65 and older. And that's something we need to start looking at. And how do we look at that? We have different ways, right? We have different scientific methodology. I think many of you are very aware of this. We have randomized controlled trials. And this individual randomization, that's what's really important to show causation. That's like the gold standard, right? We need to make sure that when we measure a better flu vaccine, what are we measuring it against, right? A standard flu vaccine, right? And then we need to make sure that whatever we see is consistent across all seasons, because as John and others have reminded us, when you've seen one flu season, you've seen one flu season. Because the only thing consistent about influenza is its inconsistency.
Okay, next slide, please. So just to remind everybody, randomization is the gold standard. I'm not going to spend a lot on this slide, but I'm going to move right to the next slide because I think it's, sorry, I apologize, back one, my bad. And the reason I want to show this is because I want to remind everybody that there's strengths in randomized controlled trials or randomization, right? Because it allows you to eliminate any biases and any confounders, any presuppositions. When you take a study population and you split it equally in two, and then you do the same thing to both, you're good, right? That's one of the best things, but because of that, it's also really expensive to do. So what are other ways we look at effectiveness of vaccines? We do something called an observational trial. This happens after the vaccine has already gone into the use because it's been licensed as safe and effective because of the randomized control trial. And then we can go and look and see how it's actually performing in real world. So real world observational studies are really important to confirm that there is a clinical benefit to the flu vaccine. Unfortunately, you can't, we think, randomize real world data because it's already done. The vaccine's out there. So how do you randomize real world data? Because if you could, you would have a randomized control trial with real world data, which is really, really nice. Well, guess what? We can. Next slide. Let's skip this one because I want to get to the fun part. I'm going to skip this one too. This is the study. So the Fluidity HD study, which is a combination, it's a combination of two studies, the DAMFlu2 and the GALFlu2 study, is a pragmatic, randomized, real-world study with a huge number of samples because you need a large number of samples in order to show causation or to prove the concept, right? And that's what this study is. Next slide, please. So 466,000 older adults. So this is older adults, 65 and older, right? We're in a real world setting, right? This is a large sample size done in Denmark and in Galicia, Spain. These folks were individually randomized, like that's the gold standard. So these folks were randomized, and then they were then looked at in terms of their response to influenza vaccine between those who received standard dose and those who received high dose. And that sample size is critical because that's what you need to look at in order to be able to discern the differences in vaccine effectiveness that we're trying to look at, the ones that I tried to talk to you about: hospitalization, impact on cardiovascular disease, et cetera, et cetera. Next slide, please. So why do we do this? Well, you're saying, well, we're already moving this forward, right? We've got policies going forward on this. So why are we doing this? Well, the reason we're doing this is because as of right now, we've had a lot of really good observational studies, test negative design studies that kind of suggest that there is a benefit, in fact, show that there's a benefit of high dose or enhanced vaccine in terms of versus standard dose vaccine. However, there has been nothing that was powered, right, to look at the differences between the high dose vaccine and the standard dose vaccines against those severe outcomes that we talked about earlier: hospitalizations, cardiovascular disease, right? So this study, again, is a combination of two of these pragmatic, randomized, observational, real-world studies to come together and try to give us the answer to that question. The next slide. So one was published, DAMFlu was published in the New England Journal of Medicine, and GALFlu was also published in the New England Journal of Medicine. Remember, this is a pre-specified pooled analysis of two methodologically harmonized trials. People will sometimes come to me, well, wait, how can you combine the two of them? They're two different studies, right? No, they're not, because they were pre-specified and methodologically harmonized. In other words, before anything was done, these groups came together, agreed on a harmonized methodology, and moved forward in their separate locations on that. So that's the reason why you can harmonize these two trials into one study called the Fluidity HD. That's the study that combined both of that, and that was published in Lancet. So let's take a look at some of those results in the next slide. So the primary endpoint, which was hospitalizations for pneumonia or influenza, you can see that there was an 8.8% improvement of the high dose over the standard dose vaccine. I wish we had a placebo control here because I would love to see that improvement because I think it would be dramatic. But again, as I said, standard dose is your ethical control, right? I'm sure that the study designers can go back and take a look at some data and see whether there's enough of an unvaccinated population. And I have said that to some of the researchers. Maybe this is something we can see later on. And if you look at some of the secondary endpoints, first take a look at lab confirmed influenza hospitalizations. So these are hospitalizations that were confirmed by PCR that it was due to influenza. 32% improvement of high dose over standard dose. That alone is cost effective. And I'm going to let you look at the others on your own time. Next slide. This is the summary. The 32% I showed you, influenza I also mentioned. Cardiorespiratory improvement, 6.3% improvement over hospitalizations as a result of cardiorespiratory disease. And all cause, that means any cause for hospitalization, 2.2% improvement, high dose over standard dose. Again, I would argue all this is great data to suggest you need to be following the data and using this high dose enhanced vaccine. But I think alone, lab confirmed influenza is significant. Next slide, please. They then went on and took a look at one of the secondary outcomes, which is published in Circulation magazine. And this specifically looked at the cardiovascular outcomes. What are the differences between the high dose and the standard dose vaccine with regard to cardiovascular outcomes? Let's see that on the next slide. Again, said this already. So the endpoints are anything that has to do with history of cardiovascular disease. So this was hospitalizations for any CVD, any hospitalization as a result of respiratory disease, myocardial infarction, which is MI, okay, heart failure, which is HF, et cetera, et cetera. So that's what the endpoint that they looked at in this study. Let's see the results. So if you look at the results once again, if you think about hospitalizations for any cardiovascular respiratory disease, the high dose was 6.3% more effective than the standard dose. If you look at hospitalization for heart failure, wow, look at that, 21.3% improvement of high dose over standard dose. For all the cardiovascular patients out there, if you're not getting the enhanced vaccine, you should be asking for it. Next slide, please. So this is the conclusion slide. I'm out of time, even with the pause, I'm running about 20 minutes. So I'm going to stop and just basically kind of remind everybody, right, that among the cardiovascular outcome for this group, again, significant improvement of high dose over standard dose. Next slide, please. These are the wonderful teams of researchers, both in Denmark and in Galicia. I've had the privilege of working with Tor and with Federico. So this is an amazing honor to be able to present their data. I'm just a messenger here. Next slide. And then just what I said earlier, influenza is unpredictable. Subclade K, anyone thought about subclade K? Last year in August, I was in Incheon, and no one was talking about subclade K. Subclade K is now the word of the month, right? So the only thing certain about influenza is this uncertainty. That's why we need to be prepared. We do know these vaccines work. We need to be protecting our 65 and older populations, and in doing so, we're protecting our economies. So thank you all very much for listening. I appreciate this, and I hope we have time for some wonderful questions. Thank you, Ryan.
Excellent. Thank you very much, LJ. I think face similar challenges with enhanced influenza vaccines. Okay, we can go to another question maybe that will be directed maybe to some of the folks that are here in the room with us. And so one of the questions is that we've heard a number of examples today in terms of how data on the burden of and vaccine effectiveness, cost effectiveness are informing policy. From your experience, what is the most important enabler that helps move an economy from evidence to implementation? Is it the need for better data? Is it financing mechanisms? Is it provider engagement? Is it something else? Maybe I'll just kind of direct it to our speakers that are here in the room. If you have any thoughts in terms of what is kind of that most important, or maybe just like a key important enabler that helps move an economy from evidence to implementation.
Well, certainly presenting the evidence in a cost effectiveness form is an absolutely essential first step. You have to accept the fact that many of the policymakers we'll be working with have a limited amount of time to become very literate in very specific health issues, and instead present it to them as a matter of resource allocation. Along with that, I've found a great deal of efficacy in taking advantage of the size of the cohort that we are talking about. As we're talking about somewhere between 15 and 25% of the population of my region, the Asia Pacific, either now or will shortly fall into that over 60 age group. That is a huge segment of the population with the political weight and the economic weight that comes from that. So if you can identify spokespeople that reflect accurately and are respected within that cohort that can speak to the policymakers in a given economy regarding the interests of that cohort, then you can actually put that heft to use within the political structure of the given economy we're speaking of to press for those resources to be allocated in this way.
Professor Ng or LJ, do you also want to comment?
Just a quick point. I think policies by nature are blunt. Because they are blunt, that's why implementation has to be as sharp as possible. So from an implementation perspective, typically, most of our policy comms and implementation assumes one size fits all. But I think the presentation by our colleague from Chinese Taipei, I thought brought up a point that resonated a lot with me. He was talking about, vaccine hesitancy among older adults, and about 60+% worry about side effects. 20+%, felt that flu vaccines weren't possible because of current health conditions. If we communicate one way, it's not one size fits all approach. In fact, what would resonate for those who are hesitant because of side effects, we need a different strokes for different folks approach, right? So the idea for these people is to say, look, debunk the myths about side effects. Then for the other groups, it may be reasons that resonate with them. So I think the point here is we need to move away from a one-size-fits-all approach to a different strokes for different folks approach. Then implementation can be as sharp as possible.
I don't have much more to add except all the above. I think all three are important levers. They need to be holistically combined, right? I think you can't do one without the other. So supporting everything that's been said by John and Ruben, I think you can't educate the public and tell them that they have a better vaccine if you don't have ways to get them the better vaccine, right? At the same time, you can't just go ahead and implement a policy because that's blunt without a way to integrate that policy into actual delivery of vaccines to the public. So it's you got to move them all at the same time. So I think that's very fundamentally important. What I do think is that it's economy specific. And that is for Ruben's point as well, is that, I was noting with Dr. Wong's one study that his effectiveness of flu vaccine was really low. Ours in the United States for that same flu season was significantly higher. So I think you got to take a look at the data individually at your own economy and decide, what is the data that's going to drive the questions that you're hearing. If it is about safety, you need safety data. If it's about, hesitancy, you need hesitancy data. And if it's about effectiveness, then you need effectiveness data.
And actually continuing, we actually have a number of kind of different kind of questions that are kind of focused sort of around data. I think I'm just gonna paraphrase a couple of questions here and kind of follow on to that discussion. So for the economies that currently are kind of lacking strong local burden data, are there any kind of practical kind of first steps or things that they can start to begin to do to kind of strengthen their influenza surveillance and start generating that policy relevant data?
Sure.
Yeah.
Well, coming from New Zealand, we've had a program for many, many years called Shivers, which was supported by CDC and other sources. And why the Northern Hemisphere would fund Sentinel sites in New Zealand is because it allowed them to determine what the next year's vaccine should look like. It was critical, both directions. And there was a vested interest in establishing Sentinel sites in the Southern Hemisphere. New Zealand worked out quite well, and it has been extraordinarily beneficial for our own internal vaccination system. I would suggest as a first step for states that are looking to really take a look at what the burden is and how to address it, that you need Sentinel sites to be stood up, and they need to be sustainable, and it needs to be broad enough so that you aren't generalizing just urban areas or just rural areas, but across a given economy. There does not need to be a huge number of them necessarily, but they do need to reflect the breadth of the population and the settings.
We got it.
Okay, perfect. Okay, excellent. Okay, so another question here is, what opportunities do you see for APEC economies to collaborate more closely on influenza policy, whether it be surveillance, data sharing, evaluation of vaccine impact? Are there things that APEC as a kind of a regional body can be working on that would be useful?
Let me start with that, and I'm going to turn to John and Ruben because they are obviously APEC here, right? So I think it's important to think about collaboration across your recommendations and policies. I think we've seen this in the in Europe, where when you have multiple European Union countries implementing different policies with regards to vaccinating their elderly, all of a sudden there's confusion, right? Because if Poland does this, and the United Kingdom does this, and the Netherlands does this, there's a lot of confusion in the messaging to the public. And I think across APEC economies, I think it's useful to talk about the data that reached your goal of 75 versus 65. Because that when I heard that in Japan versus Korea, for example, or Chinese Taipei, I got concerned. I was like, okay, so what does that mean? Are they looking at different data? Or if they're looking at the same data, what is the cost effectiveness that they're looking at that made them shift between 65 and 75? All that needs to be harmonized and expressed publicly and transparently so that people know how these decisions are being made.
But my thought is that most of the time when it comes to flu and flu vaccinations, the policy owner is typically the health ministry, right? Or the minister or secretary of health. I think today's discussion has made us understand that it's just beyond health. It's really about protecting aging populations, it's protecting our economies, making them resilient. So I think this kind of intelligence is very important, which means that the health minister or the secretary of health can then work together with the secretary of industry, secretary of family and population or demographics and things like that to really increase the speed of influence from health through vaccines being a health issue to a whole government kind of issue. I think something to think about.
And finally, I would throw in, never let a good crisis go to waste. At the moment, with the basic collapse of the multilateral funding system for influenza research globally, when moments of change like this is when the vested parties, the interested parties, the experts need to come together and try to use the moment of change to create something better in its wake. And that, across the APEC region, policymakers, experts, researchers, academics coming together to discuss what this should look like, what the next iteration should look like, because we no longer have the inertia of the former system or the resources of the former system, and we need to develop something new.
Ryan, remember, influenza respects those borders. So, regional collaboration seems really smart.
Okay, so before I ask you all for your kind of parting thoughts or just like the kind of one thing you want to kind of leave this audience with, I'll just kind of turn to my colleagues to see if we are able to get either our Japanese or, okay. So since it is almost 4 o'clock and we are running up against time here, I'll just give my colleagues here in the room an opportunity if there's any kind of final thoughts you'd like to leave with our audience.
Demography comes for us all. It's the change is coming. We're already in the midst of it, and it's going to accelerate. influenza is a particular risk for the fastest growing segment of our population, and we will address it either in advance or we will address it when it is a crisis in our midst.
Wow, that's a good one. As I said, influenza is a keystone into getting all your patients vaccinated against adult vaccines. Just a reminder, it is dangerous in adults to use primary infection as your only outcome of vaccine effectiveness, relevance in terms of measuring that. I think you need to look more than that. You need to look at the morbidity measurements like quality of life, hospitalizations, et cetera, especially with the older adults. And I think it's really, really important to remember, follow the data. If we keep saying that we're evidence-based, if the evidence base is showing enhanced vaccines make a difference, then you need to follow that.
I think we really need to get the word out. I meant it. I wasn't joking about it when actually talking about, the size of conversations around flu and flu vaccines. I mentioned just now, right? We talk about CARs 50 times more than flu and flu vaccines, bubble tea 2 times more. So it just means that there's a lot more work to get the word out. And it's really important to create that groundswell so that it's not us, policymakers, think tankers and academics talking about it. We need that groundswell to move the world towards enhanced flu vaccination.
Excellent. Well, thank you very much. I had some summary points, but I think you guys did a fantastic job. So I think I'll leave it with that. So if you could give a round of applause for all of our speakers. Excellent. Okay, so then just in terms of next steps, so we will be developing a report that will be coming out of this meeting. So I know we did have some technical issues with some of the audio online, but we will be developing a report that will be circulating to all of the APEC economies. So don't worry if you're online and you had missed some of the proceedings here. We will be summarizing this and sending that out. And then if everyone has been to an APEC meeting yet these past 4 days, know that no APEC meeting is complete without a family photo. So we would like to call everyone up to the front here. We can stand behind this screen here. And then if there's someone who is rather acrobatic, maybe can hop over the table and take a picture, that would be fantastic. But if I could have everyone come up to the front here, we'll take a family photo. And then after that, we will also be having a small reception in the Marriott Hotel. So you can take the buses to the Marriott, walk straight back, and we will be on the left-hand side. It'll be right across from the bar in the lounge area. So we all welcome you to come back with us to the Marriott Hotel for a small reception, continue the discussions, have a bite and a drink, and have any more reflections on this discussion. So we can have everyone up to the front.
Stop.
Recording stopped.